Welcome to the Public Health Practice Grand Rounds for January 2010. My name is Molly Mitchell, and I'm the coordinator of the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Department of Health and Mental Hygiene, I'd like to welcome you to our Grand Rounds this month on Given a Choice, Economic Empowerment as HIV Prevention Among Sex Workers. Before we begin our presentations, I'd like to invite you to visit our website to view our available online and face-to-face trainings. In addition to the trainings available on our website, such as Public Health Nursing and the many archived Grand Rounds, our upcoming trainings include Investigating Environmental Public Health Complaints, Trespass Warning Letters and the Law with Bernie Penner on January 28th. Our Core Competency Training Series with Dr. Carolyn Fowler continues, including Community Assessment and Formative Evaluation on February 19th, and Professional Partnerships and Making Data Work for You on March 5th. We're also pleased to offer Problem Solving for Public Health with Dr. Miriam Alexander on March 10th. And for those of you watching online, we invite you to email questions for the presenters at any time during this broadcast to maphtc@jhsph.edu. And if you are watching this webcast in a group, please take a minute to fill out our sign-in sheet to let us know how many are watching with you so we can have a more accurate count of our online participants. And with that, I'd like to introduce our two speakers for today. First, Dr. Susan Sherman. Dr. Sherman is an associate professor at Johns Hopkins Bloomberg School of Public Health, Department of Epidemiology, and Department of Health, Behavior, and Society. Her work focuses on understanding and enhancing the health and well-being of marginalized populations, such as injection drug users, methamphetamine smokers, and sex workers. Dr. Sherman has published numerous articles on sexual and drug risk behaviors of drug users. She has 10 years of experience in developing and evaluating social network peer outreach behavioral interventions with drug users, both domestically and internationally. She has utilized both quantitative and qualitative methods in conducting research in the US, Thailand, India, Russia, and Pakistan. She is interested in the role of economic empowerment in reducing sexual risk behaviors among women. To that end, she designed and evaluated a small pilot in Baltimore examining the effects of training drug-using female sex workers to make, market, and sell beaded jewelry. She's currently scaling up a pilot targeting sex workers in southern India, in which they will make reusable canvas bags to be sold on the Western market. Our second speaker today is Dr. Danielle German. Dr. Danielle German is an assistant scientist in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. Her research uses qualitative and quantitative methods to understand and address the social context of health behavior, with particular emphasis on issues related to urban health, HIV transmission, drug use, and mental health. She has extensive experience with harm reduction program implementation and intervention development. Her current activities include a focus on HIV behavioral surveillance, zoning, and the public health impact of social, economic, and housing stability. With that, I'd like to present you with Dr. Susan Sherman. Thank you.
Thank you, Molly. Thank you for being here today, physically, those who are here physically and those who are here virtually. So our talk is entitled Economic Empowerment as HIV Prevention, What Does Money Have to Do with It? And we're going to be talking to you today about two studies, one that took place in Baltimore and finished a few years ago, and one that's ongoing in Chennai, India. So I want to start with a little bit of context to talk about HIV risks among sex workers. Like many other populations, research is primarily focused on the individuals devoid of contextual factors. That's not a bad thing, but it's not necessarily a sufficient thing to understand the complexities of risk. And I think it makes a lot of sense why we study individuals. It's easy to get individuals in studies. We often see short-term behavior change, but it doesn't really kind of create long-term change. If you think intrinsically about condoms has been the biggest intervention with sex workers, while that's very important because it is a very effective way to prevent HIV, how women get men to use male condoms is a whole nother issue that has a lot of factors that influence it. Female condoms also have been shown to be effective, but they're more complicated, they're bigger, they're not as distributed as widely. And among sex workers, if you think about the risk, whether they use drugs and need money for drugs, economics really play a role. So in thinking about what would cut the risk at its source, one answer is money, illicit income. I want to reiterate that I think it's really important, and I continue to do research on individuals, and it's necessary, but it's not sufficient in explaining why people place themselves at risk and how we can intervene in a sustainable way. And what oftentimes is unaccounted for in a lot of the studies which we do, because before the last few years we haven't had GIS available, we haven't had all these great data sets that explain neighborhoods, for examples. One thing that's really been unaccounted for is the broader relationship and structural factor that shape women's risks, that sometimes economic policies that seem very distal may indirectly have an impact, and that's hard to study, that's hard to measure. So we posit that context really counts, and epidemics follow society's fault lines. So when you don't have a healthcare infrastructure, I mean, a horrible example, of course, has been Haiti, which is on all of our minds, without building codes. Catastrophes happen, and HIV, unfortunately, for the past 20 plus years, is a horrible example of that, the HIV epidemic really has settled into low-income countries, to low-income populations within wealthy countries like the United States. And throughout the world, fairly consistently, poverty characterizes HIV risks, although it's much harder to intervene on that distal factor of poverty. All right, so I think it's important just to say that poor countries are more likely to have general epidemics, HIV epidemics, and countries with more income disparity, why the US has higher prevalence estimates of HIV among subpopulations compared to Western Europe. Some have attributed that to the disparity between the wealthy and the poor. And these are really hard issues to kind of focus on structurally. Whenever I give this talk, I think it's important to say everything I'm calling risk behaviors in the lives of the women who day to day need to feed their children, pay their children's school fees, fix their, meet their drug habits, it's really coping mechanisms. So I, as an epidemiologist, social scientist, will use the word risk behaviors, but in the day-to-day life of a woman, they're making choices that actually benefit them in the moment, and I think that's important to acknowledge. So to take a step back, a structural intervention, because I've been talking about structures, is an intervention that actually targets the political, legal, physical, social environment, and not necessarily the individual themselves. So some examples of that is if you have drug paraphernalia laws that were changed so that people can carry syringes, who go to needle exchanges, that's an environmental change that actually reduces risk and HIV prevalence at an individual level. Things like seatbelt laws, which actually mandates a behavior change that has been shown again and again to not only is it I can't imagine getting in a car without putting on a seatbelt, but it actually greatly reduced traffic fatalities. Or programs that are aimed to reduce poverty is another example of a structural intervention, like the Grameen Bank microfinance interventions. And what Danielle and I will be talking about today is somewhat of a version of a microenterprise intervention. So with that, I'm going to turn it over to Danielle to talk a little about the work we did in Baltimore with the Jewel study.
Hi. So it's my privilege, really, to talk about a project that we worked on together a few years ago. And it was here in Baltimore among drug-using women. We're called the Jewel Project, and you'll hear much more about that. But first, this is Baltimore. This is the Baltimore that many of us know quite well. It shows the gleaming harbor. It shows the big, tall buildings. And this works really well for the visitor center to be able to promote what it is that's good about our city. This is also Baltimore. And this is a Baltimore that is quite real for a very large percentage of our population. And what you see here are abandoned buildings. You see not a lot going on. You see trash in the street. And you see kids growing up in a neighborhood that doesn't have a lot to offer. And I think the combination of these two pictures really gives a sense of some of the stark disparities that exist in the city, particularly economically. And this gives a little bit more detail about the socioeconomic context here in Baltimore. And what you see are the unemployment rates for Baltimore on the top line, and then compared to the United States and to Maryland over time. And like most other places, Baltimore recently has had quite a spike in unemployment. But if you notice, Baltimore has been here before, and we actually have quite a legacy of unemployment. This is not a new thing, and it's been with us for a while. So currently, our unemployment rate is about 11%. There's an additional 35 approximate percent of people who are considered not part of the labor force at all. These are people who are not working, and they're not currently looking for employment for a variety of different reasons. 35% of the population earns less than $25,000 a year. About 20% fall under the official poverty line, and then about a third have less than a high school education. So these are complexities that just add to the overall sense of economic challenge that exists in the city. Baltimore also has some of the highest rates of heroin use and a quite substantial level of crack use as well. And for drug users, the socioeconomic context is perhaps even slightly more complicated. So drug users tend to live in conditions of very severe economic disadvantage, also have very low levels of education, and their job opportunities are limited similarly to people who don't use drugs. But additionally, they face some specific barriers to employment. And this includes generally a high or a limited level of job preparedness, additional complexities to working due to challenges with addiction or with maintenance of drug use, and then specific barriers to participation in job training programs, to participation in certain sorts of jobs that will require a drug-free environment that just makes it very difficult to maintain a steady source of income. And then couple this with standard financial need, as anybody has, to maintain their family, to maintain their housing, that sort of thing, and the very real costs that are associated with using drugs. This creates a circumstance of relatively challenged bargaining power. And when you think about HIV risk, particularly for women, where a lot of it comes down to being able to convince a male partner to use a condom, when that male partner is somebody who contributes to their rent and their bills, or is somebody who is choosing whether or not to pay, based on whether or not a condom is being used, then the possibility of HIV risk reduction is quite compromised in that sort of context. So this shows that train of thought a little bit more clearly. And so what you see is that the limited job opportunities coupled with specific barriers to employment create a quite constrained economic context where, in reality, the most viable economic options for drug-using women in particular, drug users overall, are engaging in sex exchange behaviors, participating in the drug economy, whether selling drugs or other roles within the economy, or various hustles which have varying degrees of legality. And the combination of these, each one of them has some degree of very likely increased risk specifically for HIV, risk of incarceration, and risk of continued and increased drug use, which then starts the whole cycle all over again. So it was with this all in mind that we initiated the JEWEL project. And JEWEL stands for Jewelry Education for Women Empowering Lives. And you'll see much more detail about the project, but what you see here is just one of the community sales that was to market jewelry from the project. So the study aimed first to assess just the feasibility of training drug-using women how to make, market, and sell jewelry. This was a very new idea. This is a pilot study just to see if it was even possible and worth doing on a larger scale. We wanted to see what the impact was of a program like this on women's feeling of readiness to participate in a formal job, and then to look at the impact of JEWEL on HIV risk-taking behavior. So why jewelry making of all of the different things? First, lots of people like jewelry. It's an easy thing to sell. You don't have to sell it for all that much, but lots of people like it, and you can find a pretty broad market for it. It's a pretty easy thing to start up. You need some beads, you need some string, and you need a few other supplies, but it doesn't really take much to get going. It's an easy thing to learn. It's an easy thing to teach. And then it takes a pretty short time between when you first learn it or when you start doing it and when you have something that is possible to sell. So all of this contributed to the decision of jewelry making. The project took place over about a 6-month period, ending in June of 2003, and you'll see a lot of our assessment, and we did a survey at baseline, and then we did a survey 3 months after participation with the project ended. The women that we invited to participate were recruited through targeted outreach, particularly at a local community-based organization, the Syringe Exchange, and other research studies. And we ended up with 66 women who completed the survey. 54 women ended up participating in the project. The participants were required to be female, they were over 18, and within the past month, they had traded sex for money or drugs and reported using heroin or cocaine at least once a week for the past month. And then you see a little listing of some of the items that we talked about in the surveys, but you'll see much more of that as I go on. So the intervention, it consisted of 6 two-hour sessions. It was facilitated by an individual with strong art background and also really strong training in harm reduction, which is just a general premise that of non-judgment and that really any positive change can be favorable and can be useful in people's lives. The project was located in a storefront in a high drug-using neighborhood, so we were right in the midst of people's lives. And I'm going to skip ahead to show you what the sessions were. So the first 3 sessions we met weekly. First 3 sessions were divided half and half between risk reduction and jewelry skills building and opportunities for jewelry making. And so the risk reduction content of those first 3 sessions touched on a variety of different drug and sex-related risks. And then that was followed by specifically, how do you make a bracelet? How do you make a necklace? How do you count out what beads go where? And what do you think, if you're thinking about proportions of size of bead, what are some of the considerations? So literally, how to make jewelry, how to do a fasten, and then time for people to design and create their own jewelry. The 4th session then was a specific session on preparation for a sale, on how to market, on pricing, and then more opportunity for people to continue working on the jewelry that they were creating. The 5th session was a sale that took place off-site, and then we brought everybody back together to do a review, to talk about next steps, and to have a celebration for graduation. And then throughout, we had once weekly open jewelry making sessions that were open for anybody who had participated in the project throughout the period of time. They could come in, continue working on the pieces they were working on, start new, that kind of thing. So the sales were wonderful, and you see some of the pictures of this on the side. We did 1 sale for each cohort that took place at the outpatient center here at Hopkins, and then we had, throughout the period of the project, we had 4 community sales that were just for everyone. And the women were invited to come to the sale and to be a major part of the salesmanship, and they dressed up and they showed up and they brought people to the table, they talked about their work, they talked about the program, and that kind of thing. And the way that the proceeds were divided, it was the jewelry pieces were priced relatively competitively, maybe on the lower end of the scale, but competitively. 50% of the sale of each item went back to the jeweler who made that particular item. 30% of the overall sales were divided among the participating women who participated in the sale itself, and then 20% went back into the project for supplies. So before I show you some of the changes that we saw, I just want to give you a picture of who it was that was participating in the study. The project was, or the participants were about 60% African American, about a third had completed high school, about a third had been homeless in the past 3 months, 40% had been in jail in the past 3 months, and you can see that 80% had been in jail at some point in their lives. 75% had children in their home at currently. About 10% were HIV positive, and about 20% had participated in a job training program at some point. So then we looked at a variety of different things to see what was different from when people started the program versus versus 3 months after they finished. And what you'll see as I'm going through, the bolded items are the things that that changed and those changes were statistically significant. So as I mentioned, one of the eligibility criteria that people were required to have participated in sex exchange for drugs or money. So everyone at baseline had participated in that, but at follow-up, 71% had, so it was a 30% reduction there. And then there was also a statistically significant drop in the percentage of people who reported being involved in the drug economy or having specifically sold drugs. We looked at drug utilization patterns from the start until 3 months after, and what we saw was that daily, the proportion of people who used drugs of any sort daily was significantly reduced. There was a significant reduction in daily crack use among I would say that most of the women were crack smokers. Some were also injection drug users, but there was a reduction in daily crack use. There was a reduction in the amount of people who were engaged in injection drug use. And then interestingly, we asked people how much they spent on drugs in a day. 65% reported that that they reduced the amount that they spent on drugs from the beginning until the end. And this reduction ranged from about $5 to up to $200. And on average, the midpoint of the amount of money that people spent on drugs per day was reduced significantly from $53 to about $47. And then we looked at any change in sexual risk behavior, and what we saw was that the average number of sex partners per month significantly reduced, number of sex trade partners reduced, and then we also saw an increase in consistent condom use specifically with trade partners, although we didn't see the significant change with steady partners, which is somewhat to be expected, and we can talk a little bit about that later. So a little more detail about what pieces of the program may have contributed to some of these changes that we saw. Most of the women participated in all of the 6 sessions. Close to half attended at least one open jewelry making session, and notably they received no personal compensation for attending the jewelry making sessions. Those were just available for them. And at the open sessions, we saw about an average of 5 people, and the combination of who it was that attended really varied from week to week. Over 11 sales that we had over the 6-month period, the net jewelry sales totaled $7,000, which is quite substantial. 77% of the women sold at least one piece. And among the women who sold at least one piece, what you see is the midpoint of sales was $164. The smallest amount of money that someone who sold a piece made was $29. The most amount of money that one of our participants made was $1,231. And I'll say that was a particular rock star who was part of the study who just really took to it and adopted it as a really wonderful thing for her. But there was another person who made $1,000. There was another person who made $500. So this is an outlier for sure, but it's not entirely inconsistent with other women's experiences in the project. So Then finally, we looked at factors that were associated with change in the number of sex trade partners from the beginning of the study until 3 months afterwards. And the short version of this slide is that we found that the amount of money that people made from the jewelry sale was significantly associated with a reduction in the number of sex trade partners, to the extent that we could see that women who earned $100 from jewelry making had 8 less sex trade partners at follow-up compared to baseline. And that's, in a short period of time, that's actually quite good. And when you start talking about the likelihood of exposure to infectious diseases, the fewer people that you're in contact with, the better your likelihood of exposure is. So what can we say from all of this? One, certainly that women were interested and quite successful in jewelry making. We did see some reductions in HIV risk behaviors. This was a unique study. It offered us the opportunity to see whether this was feasible, and it did seem to be feasible. Jewel was not intended to be a job training program. It was intended to be a supplement, an economic supplement. And I'll say that while for some, I think that we certainly demonstrated that it achieved that. But additionally, I think for some people, the participation in the project felt like a bit of a taster for later participation in the job market. But we certainly acknowledge that there is absolutely a need for formal job training and job opportunities that are amenable to the circumstances that these women's lives allow. Limitations, certainly, this is a small sample. It was a relatively short follow-up. This is a non-random sample, so there may be some bias involved there. And there was no comparison group, so we can't specifically tease out what pieces of the intervention may or may not have been helpful, but we have some thoughts on what may or may not have worked so well. And what I want to leave you with are some of the things that we learned doing this project that for future implementation seem really worth considering going forward. And one of those is that the open jewelry making I would say the jewelry making sessions in general, and particularly the open ones where people just kind of came in on their own time and joined us, were absolutely safe zones. They were times when women could come into a space that they perceived as safe, as quiet, as removed from their everyday life, focus on making something that was important to them, that was beautiful, that they could be creative, that they were surrounded by people who were supportive, was a really wonderful opportunity for the women that they valued and they continued to enjoy. I would say that the group aspect of it was quite important as well, where the women certainly came to know one another. They experienced things and were able to process their participation in the project with others who were experiencing it similarly and having circumstances going on outside, and they could support each other. They could remind each other that a sale was coming up. They could help each other get to wherever they needed to get to. So that was really valuable. Different women responded to different aspects of the project better than others. And so there were aspects of jewelry design. There were aspects that relied on marketing. There was the actual stringing of the beads onto the jewelry. Some people were better at different parts of that than others, and I think that future implementation would ideally try to figure out ways to support people in whichever pieces they were most drawn to. So whether there's a track system or a sort of tiered implementation, I think there's a lot of possibility there. And similarly, the structure versus creativity aspect, we set things up so that women could, they did all of it. They designed their own jewelry, they decided what colors they wanted, which beads they wanted to use, and then they did the stringing and they created the jewelry themselves. This didn't really work for everybody. Not everybody liked all of the pieces. Not everybody was good at each of those different aspects, and that affected their likelihood of sales and economic generation later on. So I think that future implementation certainly could take some lessons there and try to figure out the best way to balance the creativity versus the ability to create something that does have a good market. Sales and marketing should not be underestimated in a project like this. Keeping track of inventory, figuring out what is the most appropriate market, making sure that the items match the market, and that the venues are suited. All of that just takes time and attention. And finally, I want to say that sustainability is something that maybe we can talk about a little bit afterwards. I think it's always a consideration for projects like this. And for a project specifically like this, the economic empowerment type project, it's not just about sustainability of the program, but it's about sustainability of that economic opportunity. And so it becomes not just, can the support structure exist, but is it something that people can actually see as something viable for them to continue to create an economic alternative for them in the long run. So I think there's a lot to be able to consider there. But I just want to acknowledge the funder for this, as well as some of our fantastic staff members, Marie, Marcy, Diane, Eddie, Charles, Yinkai and Morgan, and Anne O'Leary, and then without a doubt the really wonderful women who were part of the project. With that, I will turn it back over to Susan.
Took lessons learned in Baltimore and applied them in Chennai, India. Even just listening to a lot of the things that we around marketing and design, we actually are right now, with the help of Stacy Weibly, who's the head of the Pi Foundation, we're helping to implement and explore in this study in India that I'm about to tell you about. So Chennai is in southern India. This is Chennai. You can see it's in the state of Tamil Nadu on the southeast of India, and this is a picture of Chennai. It's 70 square kilometers, 70 million people, and during traffic it takes forever, like 2 hours to get from one side to the other. It's quite amazing, and we always relate to every meeting when we're driving somewhere because traffic is really hard to predict and it always takes longer. So the aim of this pilot study was to, once again, similar to Jewel, examine sex workers' ability to be trained in sewing and produce sellable products, and to explore the effects of the intervention on sexual risk behaviors, which is involvement in sex work, and also their overall economic well-being. The study was 100 women, so we had more funds than the Jewel pilot to be able to have 100 women who were randomized into 2 arms. They were all street-based sex workers who were recruited from venues such as train stations, open-air markets, the beach, etc. So they were street-based. There were 2 arms of the trial. The first was 4 sessions, 8 hours of HIV prevention, kind of cumulative things that I learned from when I was a doctoral student with Carl Locken and started doing behavioral interventions through work that I've done with him in Thailand and elsewhere. So very interactive facilitators with a manual. And then the second was the same 8 hours of HIV prevention plus 100 hours of tailoring training. We actually started out with 40 hours of training, but it wasn't enough. And so for the products we chose, which we'll show you, so we needed 100 hours of training taught by master tailors. And data were collected at baseline 3 and 6 months. And today I'll show you the 6-month baseline. It's important to say that the street-based sex scene, the women who work on the streets, are very different in Chennai than I think what you think of in your head. For sure different than the women we worked, barring the drug use was an obvious different, with the women we worked with in Baltimore with Jewel. These women in India, many of them are married, they have children, they work during the day. Their husbands, I think, are mostly in denial about what they do. Their husbands, a lot of them drink. And extra money is needed for school fees. So for us, the best times to recruit were actually business hours. It wasn't late at night. There, of course, are women on the street selling sex late at night, but the most of the women in Chennai at these various outdoor venues are, and they look like, you'll see a picture at the end, they just look like any woman you see on the street of India, and they are. And this is an opportunity, this is one of the few opportunities they feel that they had. So the median age, there actually were no significant differences between the 2 arms. They were an average of about 34. It's interesting, in both Jewel and in Pi, it was older women. Even though it was open to women over 18, it was the older women who were more interested. They have less clients, fewer clients. I definitely think their bargaining power is more compromised because they're older and they're competing with 20-year-olds on the street. So a lot of these women also are kind of primed for change as well. We're hoping in our next study I'll talk about in Chennai that we're going to try to recruit some younger women to see if we actually can affect change in that way. As I said, the majority were married, they had children, and the median age of first sex was 18, quite late, relatively speaking, and most of it was largely with their husbands once they were married. So it's really kind of a different portrait of what you think. These are some of our participants. Actually was just in Chennai with Stacy, and the woman on the left is a master tailor who's still with us, working now. And those are, you can see women working on 3 of the 7 industrial machines we have, which is very exciting. Okay, so we looked at differences between baseline and follow-up. First, this is about looking at comparisons in income. We were pleased to see that people earned about 33% more at 6-month follow-up, the women in the tailoring arm compared to control arm. These are all significant differences. And women in the control arm, women in the tailoring arm earned about 40% less from sex work. So they reduced the sex work, which we could see also in the average number of clients. And the proportion of income from sex work was reduced. That, of course, makes sense since they were making money from selling the bags. Women were paid to be in the intervention, and they also were paid when they continued in the intervention per bag. So the proceeds actually went to the women per sellable bag, and I'll talk a little bit about where we sell the bags. And this comparison is from after they finished the training. So we're talking about once they were done, not being paid the 100 hours, because that's obviously a lot more money, 108 hours compared to 8 hours. This is actually just their average monthly income in the 6 months after they were finished with the intervention. All right, and that's just something to highlight. I think it's important to show the big difference. And this is looking at, in the presence of other variables, baseline age and also baseline income, women in the intervention arm had an average of 2 less sex-paid partners per month, and that was something we were happy to see. If you want to ask me a little bit about, these numbers are lower than we expected, and there's a lot of interventions going on in India, lots of Gates money that reached this population, and I think that we probably had women who had, in general, were previously exposed, but I'm happy to talk about that later. But regardless, the reductions in sexual risks went in the direction that we wanted, and also the direction of income per month went in the direction that we were hoping. So overall, women are interested in learning new skills and willing to work hard. We think that interventions such as this that actually address issues, for us, it was obvious it was an HIV prevention intervention to them because we had those sessions, but we also spoke to something else that stresses them out every day, much more than their HIV risk, which is how are they going to get money to pay their kids' school fees. That was always the example that came up. So I think people appreciate that when you actually address the needs of their lives in a way that's kind of beyond disease control, which is a priority for us. So I think it's a mutually beneficial, it was a mutually beneficial intervention. So to talk a little bit about bag production and sales, the bags were actually all sold in the US by a nonprofit that we set up, the PI Foundation. We have some samples today, some new designs we'd be interested in your opinions about that Carl Ackins just brought back to us from India that were just made. So Stacy here has the bags, and afterwards, if you want to see them, we'd love your thoughts on some new designs. 60% of the women continue to make bags today. So that is 8 months, now it's 9 months post the study being ended. We've sold 4,500 bags in 11 stores at 3 conferences. We had an event and also through internet sales. And we're very excited that we're actually producing the bags for the Global Health Conference this year, 2,100 bags, as soon as she sends us the logo, which, is of concern because we have like 3 months to do that. But anyway, it's very exciting that we have. That's our biggest order yet. So we started making bags, this tote, in October 2008, and I have to say, it was probably the worst thing we picked as a first bag. The material's so heavy. I'm partially to blame. It's so complicated. The stitching is really hard, and that's likely why we needed 100 hours of training. For the next study we're doing, we're starting off with a few much simpler products. And this was a big lesson learned from Jewel that It's really important. Obviously, we're not going to have women designing the products, but we needed to be better at knowing what, matching the skill level, women feeling good about creating something and not getting frustrated. In April, we introduced, and our sales were kind of slowly continuing, a lunch bag. And the best thing we thought of, and I attribute it in part to my liking of wine, was to actually make a wine bag for wine stores that have the store logo on it. And this is when the sales really skyrocketed, because our orders have been 500 and 650 bags at 5 different stores. This example is a 6-pack wine bag for the Wine Source, which is in Hamden. And I promote, if you want to support PI, it's a great place to buy, because they actually are donating all of the proceeds back to us, which is really fantastic. All right, so every bag, that's the wine bag on top, and another tote bag that comes in different colors with different fabrics. Every bag actually has a logo. This is the logo that goes in the cotton bags, because it's not organic, the material that we use for the wine bags, but we have another logo because we always want to promote the social cause aspect of this project. It's about environmentalism, it's about women, empowering women, and it's about HIV prevention. So today, as I mentioned, we have the PI Foundation, which is housed in Baltimore. We continue bag production. We're developing business plans, marketing plans. We have lots of angels and volunteers who help us in this process, students who are doing this for projects, and hopefully we'll be able to pay other people to do these things as well. We just received a great score on an R01 that hopefully, when we get approvals, will start in the spring, summer, or fall. And it actually is going to be 500 women that are going to be randomized half and half to 100 hours of English and 100 hours of tailoring. So we're happy that we have the funds now to actually do a true attention control, and the follow-ups will be as long as 18 months. I think it's really important to end with the voice of one of the women in the studies and not my voice, even though I'm going to talk through your reading this. This is Aisha's 35 years old. She was one of our pilot participants. We did some qualitative interviews at the 6-month follow-up. She's been in sex work for 5 years, and she felt she had to. Her husband drank. They had no money. Her son had to stay home, actually, because there weren't funds for him to go to school, which he needed to go to school. So she had to make this choice to go into sex work. And as she said, if PI delivers what I'm hoping it will, maybe I can tell my other friends to trust me. There's so many women out there who are hoping for a new life will come their way. I want to acknowledge NIMH, who funded our pilot, of course, the women of PI and PI staff. We collaborate with a fantastic organization in India that runs this whole study, YRG Care, particularly my colleague Krish, who has worked the way through, and Stacy and Catherine, who've run the PI Foundation. And I want to leave you with an image we took a few weeks ago of women, and Frank, if you're noticing, they're smiling. They don't always smile for photographs. This was the smiliest photograph we took. And if you're interested to see more about the project, visit our website. Thank you.
Thank you very much, Susan and Danielle. It was a fantastic presentation. At this time, we do have an opportunity for people to ask questions, Q&A, both live for people who are here as well as people who are watching online. And if you are watching online, please email your questions to our email address at MAPHTC, which stands for Mid-Atlantic Public Health Training Center at jhsph.edu. So while we're waiting for our online audience, why don't we go ahead and, yeah, right here.
First off, I'm sure everybody feels the way I do. This is so cool, and it's wonderful to hear about. And I have a question. This seems, thank you. This seems very obvious to me that this would work, and I'm not surprised by your results. What I'm wondering about is, broadly in the public health field and with the funders, is this easy to promote? Are people buying it?
I will say that we had wanted to expand the Jules study to be a large trial, and I think rightfully so, we never convinced the study section that we could do that. We could sustain women in this type of endeavor, make enough money to sell jewelry. So it took, really from 2003 to now to be able to do this. And I think our thought processes develop, but the time is really ripe for structural interventions in the HIV world. So that's one thing. As far as bag sales, which is a separate issue, if you think we can sell enough to sustain women, there's no doubt, especially if, I mean, we're hoping we have the capacity in a few years to make the bags for the AIDS conference, which is 35,000 bags. I don't know if we're going to be to that point, but since we have different markets, wine stores, which there are plenty of, conferences, et cetera, and as our website gets out, we hope that we're going to be able to actually be self-sustaining. It's why the business part of this side of this project is so important, because absence of funding from the NIH in 5 years, we're really hoping that we will be self-sustaining as an organization.
And two more quick questions. Do the women do any work with budgeting?
Not at this point.
Not at that point. And do you see this coming back to Baltimore?
It's a good question.
Okay.
I want to say that we actually did sustain the Jewel project, and Danielle and I were both intricately involved with the rock star, whose name is Sissy, who sadly died a year and a half ago. She started an organization called Gifts Encouraging and Motivating Sisters, Gems of Hope. And so we continued, even though we couldn't get funding to do a bigger study, we both worked very closely with Sissy with this nonprofit. Lots of mistakes were made, lessons were learned, but we actually tried to make it sustainable. The jewelry part here, with us advising this woman who just took to bead making like nobody's business. Necklace making.
Okay, right here.
I have two related questions, but first, thanks for a terrific presentation, and your work is fabulous. So one question is, are there resources available in the RO1 grant to make each intervention available to the women who participate in the other one at the end of it, like the English training and the tailoring training? And on a related point, is it possible to think about collaborating with microcredit organizations to sort of scale up the availability of this training?
Great question. We actually, not to the English. So the 250 women who graduate from English all will have the opportunity, all will have the opportunity to then be trained in bag making. We didn't think of reversing it. The more important thing for us, because we hypothesize that they'll benefit more greatly from being involved in the bag making, we're opening that up to everyone. We have funds for that after they're finished with their 18-month follow-up. The second question is, we actually are going to do 10 hours of training on social entrepreneurship for the women in the RCT. We think 10 hours will be enough to start women on budgeting and savings and financing. And we're actually working with someone who works at a microfinance organization in Chennai that will help guide us on that process. But yes, this could be scaled up much bigger, but this is what we're doing now because it was so hard to kind of contain it, just as, and what we came up with was training people in tailoring. Chennai also, a percentage of the clothes in this room were likely made in India and could have been made in a factory there in Chennai. So just like Danielle talked about in Jewel, we wanted to spark people to actually see themselves doing something positively and making money and being proud of how they make money. We don't expect everyone's going to keep making bags that are shipped off to the US. They may go make clothes or something else.
Well, I'm glad to hear you say that they can kind of move on to make clothes, because that's kind of where my question is going, because I heard you say that obviously we wouldn't have these women designing bags on their own. So my question is it possible for these women to sustain themselves? What potential is there for these women to sustain themselves outside of the intervention without the assistance and support of the Pi Foundation?
So that's a great question. And my comment really spoke to, in the beginning, part of, I think, what we failed in Jewel was thinking that everyone could come up with a design from the first time they made a necklace. So obviously we wouldn't expect women to come up with designs the second that they got their hands on the material. That's what I meant. We've absolutely, actually, one of the women, the color combination of a bag that I haven't even seen them yet, that just got brought back from India, was recommended by one of the women who's been working with us for a year and a half. So as people, we're really trying to figure out where the collective aspect can come in, and it's a conversation we're having. How do you have this standardized, randomized trial, and then how do you actually give women some autonomy and not just have, granted it's an industry, an endeavor that's created for them, but we want them to have some control. So some of the pilot participants are going to be peer managers in training, et cetera. We're hoping to involve them in that way, and that will evolve over time. Is that it? I thought, okay.
Okay, just a reminder for people watching online, our email address is maphtc, Mid-Atlantic Public Health Training Center at jhsph.edu. Any other questions here in the live audience? Are there other speakers? No? Okay, well then that is it for today's Public Health Practice Grand Rounds. I want to really thank everybody for coming, and especially a big thank you to Drs. Derman and Dr. Sherman. Thank you.